So the next presenter is one of my colleagues. Her name is Connie Morris. She too is a nurse. Like I said, we really are focusing on having clinicians talk about these programs and share their experience, but then also having our team, who are also clinicians, interview and discuss this with our customers and share their journey. So without further ado, I think I'm good to go with having Connie. Unfortunately can't be here today with us, but she's going to be joining us remotely from Texas. Hopefully she's not experiencing this rain like we are, but Connie Morris, Director of Customer Success, I'm going to kick it over to you to go ahead and talk about the suicide ideation patients. And let's see what our current customer has to say about that.
Hi, everybody. Thank you, Dana. It's great to be here with everybody virtually. And no, we're not having rain here in Texas. I wish we were, but we're at 104 today. So we have the other situation going on with all of the heat. But as Dana said, my name is Connie Morris, and I am the Director of Customer Success for AvaSure. And as a nurse who began my career in the behavioral health sector, I am thrilled to be part of this AvaSure team that is focused on keeping patients safe. I'm also excited that we are working hard on developing resources and encouraging these types of open discussions about this specific patient population, patients that are at risk for suicide, and kind of breaking down those old walls and thoughts about being fearful of talking about this topic, any stigmas that might have gone along with it, because this group of patients is on the rise, as everyone knows, that if you're working in healthcare today, and they really need us now more than ever. So I'm also thrilled that our solutions are here to support our caregivers in accomplishing this goal of keeping patients safe. So as you heard Adam talk about this morning, and you've heard Dana mention it, and a couple of others people mention it along the summit today, we all know that mental health conditions are on the rise, and this encompasses all age groups out there in healthcare. Some statistics for you in case you are not aware. Suicide is actually the 12th leading cause of death in the US over all age groups. That's just unbelievable and astounding to me. And currently, the number of patients monitored for suicide risk has increased 165% since 2019. For AvaSure customers, 45% of our hospitals are monitoring more than 75,000 patients for risk of suicide, and that is across 45 states. So you can see there is definitely a large problem that we're trying to manage here in keeping these patients as well as our caregivers safe in our hospitals. We're very lucky today to have two presenters, two of our customers that are dealing with this actively and doing a great job with keeping patients safe. The first I'd like to introduce is Ellen Lemkuil. Ellen is the manager of the virtual clinical operations at Froedtert in the Medical College of Wisconsin, where she manages overall day-to-day operations and leads the virtual care team in their robust menu of patient care services, including the tele-intensivist program, the tele-hospitalist program, and virtual nursing and tele-observation. If you want to know anything in the tele world, you ask Ellen. As a seasoned healthcare professional, Ellen has been integral to the adoption, execution, and the impact assurance of these programs that I just mentioned, as well as several other innovative digital health solutions across the Froedtert system. Ellen has been with the system for nearly 2 decades and remains steadfast in her commitment to care delivery, optimization, and with specific interests in care coordination and strategic development. So welcome, Ellen. And our next customer is Rachel Krajnovich. And Rachel comes to us from the HCA system in Kingwood. And she has been a nurse for 23 years, started working for HCA in 2002 when she moved to Texas from Iowa. I'm sure you got a little bit of the culture and heat shock when you did that, right, Rachel? And
yes.
she's been a house supervisor since 2006 and became director in August of 2022. So you've been managing the TeleSitter program for about a year now.
Correct.
Yes. So welcome to Rachel as well. And so we're going to go ahead and get right into some of these questions on this very important topic. We've already had a couple of people write in, so with some questions, and I'm sure we might get more. So I think let's start with a question to Ellen. Ellen, can you tell us what you think is unique about your patient population and or community needs?
In Southeast Wisconsin, and specifically, we're struggling with resources for mental health, and we have individuals that can't see someone outside of the organization, so they come into our emergency room for help. And sometimes we have difficulty finding placement for them, so then they end up getting admitted into the hospital setting. So this is a concern that we have mainly in Wisconsin.
Mm-hmm. And have you, do you think that there's any influences that might be contributing to your need to monitor other than what you've told us?
I don't think so. We have patients that come in, they get assessed in the emergency room to determine what level they are and whether we need to keep them on board or try to find some outside resources for them. It's just difficult here in Wisconsin.
Yeah, I think people are feeling that all across the country as well, too.
Agreed.
Yeah. Previously, have you been using primarily one-to-one sitters on this patient population?
Initially, they started having one-to-one sitters with any patient that had suicide, regardless of the level. And in 2015, when we started teleobservation, they were a little hesitant to utilize our services because these patients are very vulnerable. So we started with having a one-to-one sitter and teleobservation combined until they felt safe enough for us to monitor their patients. But for our patients, they start with high risk, moderate risk, low risk. High risk does still require a one-to-one sitter. Moderate risk, we can monitor, teleobservation can monitor, which by having us monitor the patients, that saves us from pulling someone off of the floor, a caregiver off of the floor to sit one-on-one with them. So that kind of gives them a little advantage there. Low risk patients, we do monitor them. We found that moderate to low are okay for the teleobservers to monitor. High risk, they really need somebody in there because they are determined at that point. And for moderate risk patients, they can go one way or the other. They can become low risk or they can become high risk. Sometimes they know they're being monitored. Someone's checking on them every 30 minutes or whatever. They kind of can gauge when that they can do something with nobody in the room. So with teleobservation, our eyes are on them 24/7. We can talk to the patients, calm them, and get help right away if they need it. So.
Right. And I think routinely, it sounds like you all had this as well, but we see customers all across the country that have been utilizing that costly one-to-one sitter across all segments of suicide risk suicide risk level patients. And, that's just, first of all, that type of usage is both unproven and really unsustainable, especially in today's world and the challenges that we are seeing with the labor shortage. So I commend you for implementing this type of program and kind of jumping out there. Love the stair-step approach that you're talking about, where you use the TeleSitter device, the remote device, as well as the one-to-one sitter, and got your staff over that hump, that stigma, right? So that's really great. Rachel, for you, can you tell us a little bit about the program at HCA Kingwood?
Yes, ma'am. How are you today?
Good. How are you?
Good. So originally, when we purchased the program, we did not have any other alternative but to have one-to-one sitters. We have a heavy population of behavioral health patients. We're a little bit north of Houston, and so a lot of the small towns, even north of us, come to our hospital, and south as well. Like some still come up to the Kingwood area. We have an area in emergency room that's a kind of a contained area. The doors, they shut, they're badge access. You have to actually push on the door for like 30 seconds before it actually opens. So it helps deter some of the elopement risk. And we have a couple cameras there in 2 of the rooms that are ceiling cameras so they don't get damaged. And then prior to COVID, we had put a lot of our admitted behavioral health patients on a specific unit. And so we have 2 cameras in the ceiling on that unit. Now that unit we closed down during COVID, and so we have not centralized the location for inpatient population to that unit again, but we do have 7 mobile units as well.
Okay. Available.
Yes, so we have we use them for low to moderate risk as well. Of course, high risk has to have a 1-to-1 here at Kingwood as well as the other lady, and we also use them for fall risk, and we do anybody in restraints outside of ICU. We put a camera on them as well.
Oh, that's great to know. And I'm glad that you mentioned our ceiling cameras because as we know, in the hospital setting, real estate is really at a prime, right?
That's right.
Especially when you've got the high level care areas like the emergency department, the ICUs, where you have lots of equipment. So those ceiling devices are available and they do quite well with the cameras, and
Yes.
the views on those cameras.
The ceiling cameras are really the best when it comes to the behavioral health, just because of their location. It can't be used as a weapon. It's not going to get damaged like if it was on wheels.
Yeah. Those are all really great points. Ellen, did you have something to add?
I did. So she was talking about they had a unit where they put these behavior patients. So the beginning of this year, Froedtert decided to open up a 16-bed locked unit for some of our most vulnerable patients that have behavior and mental health issues. They decided to monitor their own patients. And so for the first couple of months, they monitored them themselves. The cameras, of course, are in the ceiling. And then due to staffing shortages, we started helping them out. And we are currently in the process of a pilot for us to take the patients back and monitor their patients to keep them safe. And so far, the pilot's going very well. The staff have now, they have faith in us that they feel comfortable with us watching their patients, so we're keeping them safe. Their patients have different workflow. We have different workflows for their patients compared to the other patient population for our fall risk and safety of tubes and lines. And any behavior risk patients that are in the main hospital units, they're not allowed to do certain things where in the locked unit they are because they were locked. And we have a camera in the hallway and in their day room, so when they leave the room, we can see them. But in the regular hospital units, we can't. So a little bit different setup and a little bit different workflows, but we're making it work. We really are.
Yes, it sounds like you're doing an excellent job. And I love that you both talked about the changes in the environment, kind of the architecture. This patient population, because of the sensitivities and their needs, their clinical needs, there's often some challenges that go along with that. So you're seeing that you can still offer, monitor them remotely and safely and make the adaptations that you need to for that care environment. So that you took care of one of my other questions. So that's great. I was going to be asking that. And it's wonderful to hear the differences in the systems and how you're handling that. So thank you for sharing.
Actually, at Kingwood, I'm working with IT and possibly division. We really need to expand our system. So as now that we've been, since the COVID big, where we had a lot of COVID patients, and now that's dwindled off and we're opening our units back up. We're actually getting ready to open our last unit in August. And so we'll be back to the 460 beds. So our system actually is a little small. So we actually need to expand it for all the things that we utilize the cameras for.
Yes, all the different use cases. That's a great point there. And I think sometimes when we're working with customers, we get laser focused, like Dana said previously, on falls and things. And so you really want to broaden that definition of safety, right? How can we keep all different types of patients safe? And specifically with the suicide risk patients, what challenges, I'm going to send this question to you, Rachel, what challenges do you think your organization has faced during, in trying to monitor those patients? Do you see that the population has evolved over time, an increase in the number of patients you're trying to monitor, and how are you addressing that?
We definitely have an increase in the number of patients. This year over year, the numbers increase. I mean, when we first started the program, we were using one-to-one sitters, and we were using maybe 5 to 6 a day. I mean, we've had up to 15 in a shift. So definitely the numbers have increased over the years. Again, that's one reason why we need to expand our system as well. For many reasons, for financial reasons. Since COVID, our numbers have definitely changed as well. How we're dealing with that, again, the locked area in the ER, we have a couple cameras, plus our high risks, we definitely keep back there in the locked area. If they're emergency room patients that are medically cleared, waiting to go to a psych facility or waiting for psych to come and clear them. If they're inpatients, though, we usually put a one-to-one on. If we don't have a camera available for the low to moderate, we still tend to use a one-to-one until psych sees them and either clears them or we get them placed. Sometimes the low and moderates don't need a sitter anymore, but if they have a hold status, then we tend to keep the one-to-one there. So that's how we've been really dealing with it. Again, why we're up to 15 sitter a shift sometimes.
Right. And I know that can be really challenging. Ellen, I see you nodding as well. Are you using a similar kind of triage level for these patients? Yeah. And maybe starting them with the one-to-one, moving them to a camera or vice versa, depending on their clinical needs?
So when they are admitted to the emergency room or to the hospital itself, they have a suicide screening. We use the Columbia Suicide Severity Rating, and that will determine what level they are. And then if they're high risk, they do require one-to-one. If they're moderate or low, they do a teleobservation to monitor them. But they try to do the assessment shortly after they're admitted, either to the ER or to one of the units on the floor. So moderate risk is teleobservation, but the bedside team still does their 30-minute checks as well. So.
Okay. All right, great. Well, I'm glad you mentioned the Columbia scale. Do you use a risk scale as well, Rachel?
Yes, we use the same scale, and then after our site team comes to see them, we get an overall risk level which will be the final determining factor whether or not we can go from a one-to-one to a camera, especially on the inpatient side. You know, if they were high risk to start with, but they ended up being low to moderate, or sometimes we have to wait, and then the next day they come back and do a reevaluation and their level goes down, then we can reassess at that time.
Okay, great. Sorry, I got a little, then my Texas allergies are getting to me, I think. Excuse me. Okay, great. Let's see, the next question that I wanted to ask both of you, we'll start again with you, Ellen. What types of steps did you take to get staffing comfortable with these patients?
So we started with a sitter and teleobservation until they were comfortable that we were able to manage the patient. We would intervene first. The sitter was there just to make sure, you know, that nothing happened. A lot of times when the patients come in, they're not really sure what their level is. So sometimes they think they're moderate and they could be high. So we always start with both, and then they would get more comfortable with us. But now we've been doing this for so many years that we have a lot of workflows and processes in place to where they can start with just teleobservation right away. And a lot of times they keep us. Sometimes we feel that we can't keep the patient safe, then we reach out to them and we work it out and get a sitter if possible. So.
Okay, great. Did you do any additional education or hold any different classes, some online education?
So from what I understand, our teleobservation team has very extensive training for all patients, not just suicide risk. They do de-escalation training as well, but we do very extensive one-on-one training with the staff for several days before we even put them out on the floor to monitor any patients, including the suicide risk patients.
Okay, great. Rachel, how about you? Did you run any specific education or take any measures to help your team get more comfortable in monitoring this specific patient population remotely?
Yeah, so our sitter team that we had when we implemented the telesitting, they were PCAs already, and then they went through all the training, and we had a specific group that was only doing the telemetry, you know, the telesitting. And so they went through all the training and were really comfortable, and then they trained the rest of our staff. We didn't really have anybody that didn't want to do it once they got into doing it. Now, our current setup, because we have about 40 sitters. All of them rotate through telesitting. They do training, and then if they are not comfortable with the setting, then we don't put them there, right? So then we still have a specific list of people that want to do that. 70% of our staff are PCTs, so they're not just coming in to become a sitter. They've already been like a CNA or went to our HCA Star Tech training. Plus we do CPI, which is crisis prevention intervention training as well for all of our PCTs and PSAs.
That's excellent. I love the extra step with the CPI. So Ellen, did you have something?
Yes, I did. So when we first started this program, we started with staff within the hospital, CNAs, or personal sitters. We started with that staff, but over time, we learned that a lot of this job is more communication, customer service. And so we initially hired just CNAs. When we first started, we had 2 cameras and we rotated CNAs from the floor. And then we moved off site. And so we are in a different location, and we just started hiring our own staff and started hiring people that had customer service backgrounds and then trained them. with a lot of help from AvaSure with the training modules were extremely helpful. And right now we have some CNAs still. We have people that have customer service backgrounds. We have phlebotomists, LPNs, respiratory therapists. So we have a wide variety of staff with different backgrounds. And it seems to really help a lot with the team. We now have 4 teleobservation workstations. We have, I think, 62 devices and 34 staff members.
That is fantastic. I love the whole customer service angle that you're talking about, because that's so important. In the previous session that we just had, they were talking about the number one thing that they're looking at in hiring and retaining their staff is the strong ability to communicate. And especially with our suicide risk patients or any behavioral health type of patient, you have to feel comfortable. And if you get choked like I did just a few minutes ago, you just take a deep breath and a sip of water and keep going. That humanizes you. And when you're dealing with virtual care, you want those individuals to be able to effectively communicate and, you know, let the patients know that they truly are safe, that they understand what's going on. They convey that empathy, right? And even though we're doing it remotely. So I love that whole customer service aspect of it, along with the CPI training, Rachel.
Yeah. Besides the CPI, our techs also do the AvaSure education.
Yes, I was going to ask if you had the opportunity. We have the health stream modules that are available that all of our customers can access, along with lots of different resources, articles. We have a plethora of information, plus you've got your customer success team, you know, that can be available to you. So we're getting to the Q&A part here. I have one question that I wanted to ask you, which was about your patient selection criteria. You talked a little bit about that, but can you give me a little bit more detail? Rachel, let's start with you.
So when we're selecting who can be placed on telesitting, again, we are based on the CSSR, the screen that's done in the emergency room. And then if they are high risk, they're excluded from a camera. If they're low to moderate and we have a camera available, then we will place them on a camera. If we have multiple that are available and to go on the camera, we would start at the lowest level, right? So we would go with the low risk over a moderate risk, and we'd keep the moderate on a 1-to-1.
Okay, great. And Ellen, do you have anything to add there?
Nope, ours is the same way. Our nursing staff do, they reevaluate the patient every calendar day to make sure that they're either at the same level or their level is reducing, or if they are increasing, that we make sure we get the appropriate care for them.
Okay, great. Well, we have some really wonderful questions that are coming in on the chat. So let me pull this up. And the first one that I want to ask you is, do you have a bathroom privilege policy for these patients?
Suicide risk patients are not allowed to go into the bathroom by themselves. We have had some patients in the past attempt suicide in the bathroom, so a staff member has to be present with them at all times. They are allowed to walk around the room, but they're not allowed to leave the room, so without a staff member.
And is that all levels, all risk level?
All risk levels of suicide.
Okay, all right. Rachel, how about you? Anything to add there?
Nope, they have to be line of sight.
Okay. All right, and then we have another question. Do you monitor any pediatric patients? And if so, how do you handle those patients' needs specifically or differently?
So at Froedtert, we do not have pediatric patients. Our patients are all adults. We have Children's Hospital where all pediatric patients go.
Okay. Rachel, anything different?
We do have 2 emergency rooms, so our pediatric emergency room, but we do not use cameras there. We only use one-to-one sitters.
One-to-one sitters. Okay. Yeah, I can see that, that patient population may have a little bit different needs. So I think you've got the cameras as a backup if you need them, but you've also got the option to use the one-to-one sitter there. That is great. And let's see. Do you use any types of environmental checklist? How do you ensure the safety of the rooms? So I see you nodding, Ellen. How do you all do it there? And
so
Froedtert?
Inpatient and emergency department have 2 separate environmental checklists. For our teleobservers, they have to review the room and make sure that there's nothing in the room that can harm the patient. Everything that has a cord has to be tied down with zip ties. All personal belongings are removed. Any medical equipment, any medications, anything else that's in the room has to be removed from the room. Any sharp items, plastic bags, even garbage cans, anything that they can harm themselves with has to be removed from the room. That's about it.
Yeah. And Rachel, how about you? Do you all do it?
Yep, we have an environmental room checklist. The sitters and the virtual, go through the checklist. The nurses also do the checklist and they document that they have done a room check. We do use paper scrubs for those that are appropriate to be in paper scrubs. Sometimes it's not always appropriate and they've had to use, regular scrubs, which actually is because the patient was on virtual camera, they actually caught a female one time. She was trying to tie a noose using the gown.
Mm-hmm.
Yeah.
Yes, that was a really great catch to be able to prevent that. And that's one of the things I was going to end with, any stories that you might have, any great catches. So that's one, from you, Rachel. Ellen, do you have a story about a great catch of how the virtual sitters prevented or noticed something that, helped a patient that was at risk?
So I help out teleobservation when they need a break or whatever. And I was coming into the room and saw a patient that looked like their face was, just not the right coloring. And there were staff members in the room and the patient had somehow gotten their IV wrapped around their neck. So we stat alerted the patient and talked in the room right away and told the staff in the room they were not looking at the patient. They didn't realize. So they got the cord out from around the patient's neck. We have a lot of saves like that where patients are doing things that they shouldn't be, where our staff are able to get somebody in the room ASAP. We had a patient that had the sheets and they were pulled up around their neck and managed to wrap something around their neck. The staff member, the teleobserver, caught it and got somebody in the room.
Isn't that amazing? I think that's an excellent, example of how, virtual sitting can provide even a higher reliability sometimes because they're so focused on those patients and that, that view, it's often more reliable than the people right there in the room, just as you said, Ellen. I could not have scripted that way that your team had. Yeah. Rachel, do you have any other great catches to share or say?
I mean, again, we have great catches all the time from restraints to falls to suicide. So just being able to monitor them, we can, stat alarm when they're trying to, leave out the room. That happens several times. Patients notice that there is like an exit door and, statting it gets the nurse there right away. And, the fall as well. So we've been able to prevent, several elopements. as well. So which is really been great.
That is absolutely wonderful. I just commend you both on your programs that you're running and all of the opportunities that you have put together to keep both patients and your staff safe. I'm just checking the questions here and to see if there's anything else that, oh, I do have one here. What is the patient monitor staff ratio for behavioral health patients? Is it different?
Not for us. Our staff members, we have 4 teleobservers on every shift, and they kind of divide the patients up based on acuity level and the number of patients that we have, and they're all fully trained on monitoring both the behavior risk as well as all of the rest of the patients. So they have a variety of fall risk, safety of tubes and lines, behavioral health, staff safety. The only time we use a camera and a sitter is for staff safety patients, and we're watching for the staff safety. So we divide them up amongst the team.
Okay. Do you have an average number of ratio, like 1 to 10, 1 to 12 that you try to stay at?
Not really. It depends on the teleobservers that are working. The more experienced ones can take on more active patients, and it's mostly based on the action of the patient's activity level, acuity level of the patient. So we don't really count the numbers. It's based on a lot of different things. So.
Okay, great. Rachel, anything to add there when it comes to ratios?
Our setup right now is set for a 1 to 12. We have 11 cameras that are functioning. One of our cameras is broken and it's out of warranty, so we're stuck at a 1 to 11 ratio. But they could go to 12 with our current setup.
Okay.
There was something else I was going to tell you, but I'm trying to think of what it was.
Yeah. And we're winding down here. We've got less than 2 minutes. I'm sure we can take a look at that camera for you, just so you know. And let's see, the last question, I think we already covered the 15-minute. Do you do the 15-minute check-ins virtually is a question that came in, and then I think that's all of them. So do you round?
Yes, we use the same Q15 rounding sheet that we do with our one-to-one sitters. So we document every 15 minutes what they're doing on the camera, just like we do for a one-to-one. Also, even though our ratio is 1 to 12, looking at the screen, we have 2 virtual techs every shift, and one of them does rounds. So they go around on the one-to-ones and the cameras, make sure the cameras are functioning, and checking on the patients as well.
Okay.
So our ratio is for all patients. Each teleobserver monitors approximately 8 to 9 patients each, and they break each other. So one teleobserver takes a break, the other 3 take over their patients while they take their break. So our census rate, our ratio is a little lower, and it can be some of our fall risk and safety of tubes and lines patients are more active than the suicide risk patients. So that's why we mix it up like that.
Okay. That's wonderful. I really, again, want to commend you on your program. I'm getting the flashing clock, so I know that we are just about at our time here, and I'm going to need to pass the baton back over to Dana, but I wanted to thank you both again so much for all that you're doing to help keep patients at risk safe and going the extra mile. And I'm sure that you'll probably get some additional questions. We could go all day on this one topic that is so necessary. But again, thank you very, very much for joining us here today. And with that, I'm going to pass the baton over to Dana.
Thank you.
Thank you.
Thank you, Connie. And let's hear it for Rachel and Ellen. Yes. See, we need to plug in some claps because it's such a, like I said, it's such a great topic to discuss. Before we go on to our next presenter, something I want to enlighten everybody about that you may not be aware of, 2 things. Number 1, I know the pediatric use case is something that's pretty prevalent today. We did do a webinar last month, I believe it was, and it was all about the pediatric use cases, and it was heavily focused on those pediatric patients that have behavioral health challenges, whether it's eating disorders or if it is low to moderate suicide ideation, and how they're implementing AvaSure for that specific patient population. So head out to YouTube at the end of today and maybe you'll learn something else today. So that'll be a great day for you. And the other component, and we hear this oftentimes, is do we need to get a consent when we're monitoring these patients that are suicide risk? So just so everybody is enlightened, according to the CMS, we have a couple different things that you have to comply with. Number one, for all of you that may not be aware, AvaSure does not record any audio or video. So for that aspect, you're good to go. You don't have to get a consent. Obviously, if you were recording, you need a consent. But then also a couple other components of that is another piece of it is you have to make sure that that patient's privacy is maintained. This should not be an intervention that you have open to passerbys and people to see, because that obviously compromises all your patients' privacy, right? The other component is we do make it very clear to those patients and family members that we are observing them. If you haven't seen our technology, there's a amber dome light that will be illuminated to indicate that there is somebody watching, regardless of if you're on a ceiling device, a mobile device, or a wall-mounted device. It's very clear. The other component of that is there's an audible tone to indicate whether or not somebody is actively monitoring. So every time they go to privacy mode, there's going to be an audible tone, and that yellow light will dim. So that way it's very clear to the patient. The other piece is you want to make sure that you have a policy surrounding it. So that's one of the components that Joint Commission and DMV are going to ask for when you're watching these patients, that you make sure you have a policy. And Rachel and Ellen did very clearly convey that you need a policy. So just think about those two things. At the end of the day, feel free to go ahead to YouTube and watch our amazing pediatric webinar. It was really fun to do. I was actually a part of it because my background is neonatal nursing, so it was near and dear to my heart.